డిఫికల్టీస్ అన్ని మనం గుర్తుపెట్టుకుంటే నెక్స్ట్ దాంట్లో నెక్స్ట్ స్టెప్ వెళ్తాం, ఏదో టైం ఛానలింగ్ కానీ ప్లేస్ కానీ. బట్ ఐ డోంట్ హ్యావ్ ఎ నైస్
the first person to be. So today I think it's a very informal talk. It's not a very professional talk that I'm going to give you. It is a very quick talk to tune you for the procedures that we are going to do today. The procedures are all dependent on the clinical evaluation. Like that they will be saying. So if this pattern is going, then we call it as a witnessed apnea. And if this witnessed apnea, the apnea has been witnessed by somebody, witnessed apnea. And if this witnessed apnea is there, the next question you are going to ask the patient is he having excessive daytime somnolence? Is he feeling drowsy and sleepy in the daytime? The reason is, multiple times this will go on. The cycle will get repeated multiple times at the night. Every time he wakes up, it is called as micro arousals. And this arousal is going to disturb the quality of his sleep. So the next day he will try to compensate that, because sleep is an active phenomenon. It is no longer considered a passive phenomenon. It is an active phenomenon. It is trying to steal whenever it gets an opportunity. So even at work, it may try to steal. The sleep will try to get into its way. So you are going to ask the patient or the person, is he feeling full of energy in the daytime, or does he feel sleepy in the daytime? Especially after taking a meal, or especially if he is in a meeting or a closed door environment where the lights are off, the chance of dozing is even higher than in normal persons. So that is number 2. Then we do have sets of questionnaires like stop bank questionnaires, full sleep, snore level. These are all there, but that is beyond the purview of this meeting. So we will discuss that in our future thing. So after you get that, the next, the only way to diagnose that the patient is having obstructive sleep apnea or not is by a sleep study. Alright? So there is the diagnostic way, or 4 levels you may say. Level 1 is the in-lab full sleep study, which has all the EEGs, EOG, EKG, nasal airway electrodes, all this or that. So and he has to come and fix it back. So then we call it as levels 2 study. The EEG, everything. But at that point, there is no technician by the side, and even if the electrode falls off, he is not going to fix it. The level 3 study is only the respiratory channels, EEGs, respiratory, pulse oximetry, screen for sleep apnea. A level 3 study is enough. But if you are suspecting more into the sleep disorders, then you may need a level 2 or a level 1 regarding the sleep study. So from sleep study brings you a sleep. What are you going to gain the information from? The number of protocols or respiratory disturbance in 5 or not. If it is less than 5, then he is considered normal. Obstructive sleep apnea or hypopnea syndrome. And in the then they will also have number of apneas, it will be split in there. And then it will be split whether it is obstructive or a mixed apnea. If it is a central apnea is more and there is none of the obstructive apnea, then this patient is not having obstructive sleep apnea, and we are not the persons to treat the patient primarily. But on the contrary, as in routine we see obstructive events, then naturally this patient is having some kind of obstruction, and this obstruction is again categorized into mild, moderate and severe. So if the patient is having a number of apnea hypopnea index 5 to 15, let's say, then he is categorized as mild sleep apnea. 15 to 30, then it is categorized as moderate apnea. And if it is more than oxygen saturation, what is the lowest oxygen saturation you should take into consideration? Number is no or not. And then also into the arousals, how many arousals it's happening, what is the desaturation index, and we also look into the flow limitations if it is a level 3 study. So taking all this into consideration, then we go in for the what obstruction he is having. Yes.
For intubation, is it nasal or oral? Do you prefer nasal or oral?
It's a pad.
So that
Perfect. Midline.
but before that,
We need to do an endoscopy.
endoscopy. No.
Can one is static obstruction, another one is dynamic obstruction. So what is static obstruction? There is an obstruction all the time. Whether it is a daytime or nighttime, it is there. But the other type of obstruction, we call it as dynamic obstruction. So you can see here. That happens especially during the time of sleep. Sleep, what happens? The tonicity of the muscles goes down. So during that time, the collapsibility increases. So if that is happening only at the sleep, then we call it as a dynamic obstruction. And this obstruction not necessarily is only at the palate level that we were thinking like before. It can happen at multiple levels. It could be at the level of nose, it could be level of the velum, it could be level of the oropharynx, it could be at the level of hypopharynx or even at the larynx. So these are the 5 levels of obstruction that can happen. So if there is a patient who is having an obstructive sleep apnea, and if you just do a palatal surgery, and then you call it that you have cured him or treated him, then you are bound to fail. The reason is you have addressed only one part of the obstruction, and there could be other obstructions at various levels. And how are you going to not by rigid? Always use a flexible endoscopy. One, you can do it at the bedside in your clinic. You can assess the static obstructions naturally. If there is a septal deviation, is there a polyp, is there a turbinate hypertrophy, or is there a huge adenoids, is there a tonsillopathy, is there a lingual mass, lingual tonsils, anything you can identify your flexible endoscopy itself. But to identify the dynamic obstruction, you need some kind of dynamic assessment. And for now, we have 2 types of dynamic assessments that are available. One is drug-induced sleep endoscopy, and number 2 is dynamic MRI. So the drug-induced sleep endoscopy is where we are giving a sedation in the form of either midazolam or in the form of propofol, or now recently we started to doing with the dexmedetomidine. So when you give this pharmacological agents, you are inducing the sleep, and then you are putting the endoscope, and then you are simulating the natural sleep, and you obstruct and you look for the obstructions at various levels. Is it at the nose? From the ELA, you can see the nasal valve collapse. Is it at the velum? What type of collapse? Is it a circumferential collapse, anteroposterior collapse, or a lateral collapse? You can see all these things. And is it at the oropharynx? Is it the tonsils that is obstructing at the laterally, or is it at the hypopharynx? Whether the tongue base, is it collapsing anteroposteriorly? Is it a lymphoid tongue base? Is it a muscular tongue base? Or it is an epiglottic collapse, whether it is an epiglottis that is falling forward like a trapdoor, or is it a uniform circumferential collapse at the hypopharyngeal levels. All these things can be assessed with the drug-induced sleep endoscopy.
Sir, sorry to interrupt.
Yes.
In drug-induced endoscopy, what are the drugs and what are the dosages?
Yeah, I have the slide, I will show you that. So this is a nasal valve collapse that you can see.
Yes.
See here, this side is normal, on the other hand, this side it is collapsing.
Atish.
This is a turbinate hypertrophy. This is a polyp that can cause a static obstruction. This is adenoid tissue. This is the salpingopharyngeal fold that can cause lateral collapse at the level of velum. Obviously, as I told, oropharynx, you have the tonsils. And this is the Muller's maneuver that you can do it in the bedside in your clinic. Don't take Muller's maneuver as the standard, because it is only defective for 2/3 correctness in the level of the palate, but it does not correspond to what happens at the sleep in the level of hypopharynx. So Muller's maneuver should not be taken into consideration completely. And this is the dynamic MRI that I was talking to you about, wherein the patient is given a full meal and he goes into the MRI gantry, and there is a special software to capture this dynamic movements. Capture what type of collapses.
Like sedation is given in
When something happens, gantry will be little give a good sleep to the gantry. The setup, what it is, we we give a IV glycol and procedure, how it is being done. Nowadays, it's midazolam, but milligrams, I give 4 minutes for the breathing pattern, then give 5 mics of IV fentanyl, that also sometimes I may or I may not give. And then, most importantly, start looking at the saturations. If you are having a BIS monitor connected so that it can simulate, it can tell us whether the patient is going to the real near normal. The propofol is diluted. We give infusions that are stations of start giving the propofol in this dose. You start looking for the patient, and the end point is where you are going to stop giving any of your propofol or anything. As soon as you see the patient, no longer give the propofol, because it means that you have given a lot more than what is required. So then you have to wait, and then you have to off that extra vol, and then to the natural normal sleep, which can be seen by your BIS monitor if you have, and then you start to put your endoscope and see how the structures are collapsing. We will be doing that shortly. And you look for not just the level of collapse, you also look for the type of collapse. Whether it is an anteroposterior, whether it is a circumferential, whether it is a lateral collapse, and you look for the severity of the collapse, whether it is a mild, moderate or severe, or you can grade it as 0, 1 and what level it is happening. So we have classification. We notice all these collapses where it is happening, and you can jot it down in your piece of paper. So this is how.
Like, sir, whether we have to correlate the saturation of the oxygen.
Yes, the saturation. Yeah. So the sleep study also gives you an important parameter, that is the least oxygen saturation that happens during his regular normal sleep. So while you are giving a induced sleep, you should not start to panic if I or 80. It is even 60. Some patients may have a LSAT of 60 or 75. Goes down there, still you have a liver, because he is going down to that saturation. So if the saturation goes down, still you don't have to panic. It's going to be his actually look what's this airway during the type of desaturation, what is happening. Endoscopy. Based on this, you can see what the type of collapse you have. This is an anteroposterior collapse. This is a lapse collapse, or the ring. This is an apneic spell that is happening there. So you can have various types of collapse and various levels. Velum, it could be level of the tongue base. So the job is to understand the type of collapse, because you are going to design the surgery for the patient. I'll just go on to the importance again. That this is the important slide. Now you have done a dice. Done a dice, and problem that is or the collapse that goes to the midline, like kissing in midline of that particular radio frequency tongue base, or we may have to do an external procedure. If there is a low tongue base obstruction, you have the option of doing a midline glossectomy. And if it is at the level of epiglottis and low tongue base, you can also do what is called as hyoid advancement. And if it is only primary epiglottic collapse, then you can do a suprahyoid epiglottectomy or a supraglottoplasty. So this is taking into consideration that all the static obstructions, wherever it is there, is taken care of, and a CPAP trial is given for all the patients before you are addressing the dynamic collapse. So this is the most important gist that I want you to take from this small lecture, and based on this we will be designing our procedures, and we will be demonstrating the surgeries today. Other parameters that we also need to take into consideration is the BMI. If the BMI is around 30s, then it is more favorable for surgeries. If the BMI is of 40s, then I wouldn't jump into the surgical option. If it is even more than 35, Good.
Shall we
Yeah,
carry on with
we'll
endoscopy?
carry on. So I've completed this. Thank you.